JJ, ladies and gentlemen, dear colleagues. I just need my presentation. It's loading. There we are. These are my disclosures. Ladies and gentlemen, dear colleagues, I'm delighted to share with you these 5 points. I would like to talk with you about antithrombotic therapy in the first 2 cohorts of GARFIELD, cohorts 1 and 2. Second, a very brief snapshot on different types of vitamin K antagonists, because in Germany we do not use warfarin, we have other vitamin K antagonists, and also in Austria, so we will contrast the use of types of anticoagulants, Germany and Austria versus the rest of the world. And then it's a very important part also to see the change of vitamin K antagonist use over time in the participating countries. I would also like to share with you the vitamin K antagonist treatment decisions related to baseline data, and at the final end, the quality of anticoagulation control, how this may affect outcome. You have seen this first slide already 2 times. That is a snapshot of cohort 2 showing the split of antithrombotic treatment split down to the zone here. This is just a brief snapshot, and there is no need to discuss that in more details right now, but it is important for our healthcare providers to get then these data in the context of outcome in the next cohorts to come. Because the question is, if all these study data released from the phase 3 studies can also be translated into those countries where warfarin is not used but other types of vitamin K antagonists. I just wanted to briefly share this with you. This slide shows the proportion of patients receiving anticoagulant therapy, and this varies widely between countries. Globally, we said already, about 60% only are anticoagulated when they have new onset of atrial fibrillation. And you see the broad variety between the countries here. Of course, I know that you are very interested to see country-related data, and I must disappoint you, I don't show it in the public. If you want to approach me after the entire symposium, perhaps country representatives can get some ideas how they do. I'm very sad to say that Germany is not among the 10 countries from the right. I thought we are using anticoagulants like hell, but it's not the case. Why we have chosen not to show the countries right now, because there's still work in progress, and also we want then to go deeper in the analyses. Also with the next slide from cohort 2, the same pattern, because we need to understand if local guidelines may be different from international guidelines. We need to understand why our distinguished colleagues participating in the real-life registry are not providing anticoagulant therapy. They may have their good reasons, and that's what we still need to understand, and that's the reason why we don't share these data at present time in the public. And as expected, you can easily see that there is a significant uptake of the new oral anticoagulants, in particular in this country, but this is strongly influenced by the reimbursement question in the different countries. Very brief snapshot on the vitamin K antagonist treatment decisions in relation to GARFIELD baseline characteristics. It's nice to see that with an increase of stroke risk factors, there is also a more frequent decision to provide anticoagulation therapy, vitamin K antagonists versus no in cohort 1. The same is in cohort 2, with an increase of risk factors, or if the risk factors are present, we have a higher use of vitamin K antagonists. And it's plausible and nice to see in the real world, if the bleeding risk is higher because the patients had a history of bleeding, it's plausible that they have a lower chance to get vitamin K antagonist treatment. And here it's summarized with regard to the CHADS2 and CHADS risk factors, a higher use of the patients who are at risk seen in both cohorts, and a lower use of vitamin K antagonists in those patients who have a higher bleeding risk when we assess that with the Haas-Bled score. It's nice to see that at least some risk assessment is obviously taking place in the real world. Now, at the end, focusing on those patients who received vitamin K antagonist therapy, we can summarize and say that only a minority of patients treated with vitamin K antagonists in our GARFIELD registry achieve an adequate INR control over the first 12 months. If we focus on these almost 10,000 patients shown in the first bar, we see out of these almost 10,000 patients, only 57% got vitamin K antagonist therapy. Of these, only 81%, we have only the data with regard to INR control of about 81 to 82% of the patients. However, out of these patients in the green part of the bar, about 43% of the patients had an adequate control of INRs. That means the definition of adequate INR control was the frequency in range, not the so-called TTR according to Rosenthal, but we focused on the patient individual data, taking the frequency in range, and if the patients had a lower frequency in range of 60%, it was poorly controlled. Above 60%, it was adequately controlled. And the last slide clearly shows that adequate anticoagulation control with vitamin K antagonists is a benefit for the patients, because poorly controlled patients have higher event rates, such as stroke, major bleed, and also death. So again, we will continue to see vitamin K antagonist use in the real world. It will not be replaced by 100% by the new oral anticoagulants. We need to work on this, that if we provide vitamin K antagonists, we need to pay attention to adequate control. So let me summarize what I tried to share with you. We saw a proportion of newly diagnosed AF patients treated with new oral anticoagulants that was increasing at the cost of vitamin K antagonists in cohort 2. There was not a general increase of anticoagulation therapy, but it was in principle at the cost of vitamin K antagonists. Cohort 2 shows an increase of anticoagulation treatment in the patients at truly low risk, and we based our analysis taking the CHADS-VASc score risk factors. So those patients with zero risk should not be anticoagulated, because we also need to pay attention to the bleeding risk. There's a broad variation among countries regarding patients receiving anticoagulant therapy, and we are just at the starting point of understanding these data, being able to explain these data, and also in particular the principal investigators of the countries can help us a lot to better understand the reasons behind the figures I just showed you in the summary. Only a minority of patients treated with vitamin K antagonists achieve the adequate INR control over the first month. Room for improvement there, and in particular, by doing that, patients with poorly controlled INR perform worse than patients with adequate INR control, and this can be changed simply by improving the management of vitamin K antagonists. And the GARFIELD Registry is an excellent tool to help us educating our colleagues in the real world in order to improve anticoagulation therapy. Thank you very much for listening.
Sylvia, thank you very much indeed. We now move from INR control to the reality about persistence and compliance in stroke prevention in atrial fibrillation, and are joined by Professor Shinya Goto from Tokai University in Japan.
Thank you, Professor Keika. It is my great pleasure to honor to share with